to introduce Julie Abayomi, who's our second speaker. Interesting overlap, or interrelationship, hopefully. Thank you, Julie.
Thank you. Good afternoon, everyone. Actually, this is kind of Obesity and Pregnancy, the prequel, because a lot of this work comes from prior to what Margaret has just presented. In a former life, I was a dietitian at Liverpool Women's Hospital, and a lot of the ideas for Margaret's PhD and the study that Margaret was involved in came from some of the earlier work that I did as the dietitian at the Women's Hospital. So I'm winding the clock back a little bit and telling you kind of where those ideas came from really in this presentation. So in terms of obesity and pregnancy, the picture has really changed in recent years. We're seeing a lot more obese women in pregnancy, and also a lot dramatically increases in severity of obesity as well, so in numbers and in severity. And there was a study by Hazelhurst who looked at obesity and pregnancy in the northeast and found that the numbers had doubled from just over 7% to just over 15% in 20 years. And NICE have found very much increasing levels of this extreme obesity, which is classified as a BMI above 49.9 or more, and they believe that about 1 in 1,000 UK pregnancies now meet this classification. So 20 years ago, we would never have seen such extreme levels of obesity, so it's a really changing picture. Margaret has mentioned some of the health risks to do with obesity. They are significant, and they infect both the mother and the fetus. Women are much more likely to have hypertensive disorders, caesarean section, type 2 or gestational diabetes, anaesthetic or post-operative complications. And in fact, the confidential inquiry into maternal death in 2007 found that 52% of maternal deaths in this country were associated with obesity, and thromboembolism was the principal cause of death, which is a complication of obesity. So this was some of my earlier work, which looked at how many women we were seeing in antenatal clinic at booking in appointments with obesity. And Liverpool Women's Hospital has about roughly 8,000 deliveries a year. And we looked at BMIs over a 12-month period and found 27% of women were classed as overweight, 17% were obese, with 113 women classed as morbidly obese with a BMI above 40. And in fact, the largest BMI we recorded was 65.7. And this is booking in appointments so early, very early in pregnancy. So in terms of the guidelines for how the best way to manage these women with obesity and pregnancy, basically there are none. It's a very kind of vague, confusing picture in terms of what health professionals should recommend to these women. The current guidelines that we have, NICE recommends achieving a healthy weight preconceptionally and avoid losing weight whilst pregnant. CMACE and the Royal College of Obs and Gynae recommend achieving an optimal BMI before and after pregnancy, but warns against dieting during pregnancy. So for a dietitian sitting in clinic with a woman with a BMI of 65.7, what do you say? You know, it's not really very helpful, and I'm sure midwives feel equally frustrated. So because we don't have any UK guidelines, we often refer to American guidelines, and they currently suggest that women with a BMI above 29.9 at booking in should limit their weight gain to between 5 and 9 kilograms. And my question is, do we really want to encourage women to gain another 5 to 9 kilograms if they've got a BMI above 60? Is that a safe thing to do? So that kind of raised all these issues with me. Well, what are we supposed to advise these women to do? What is the safe thing to do? Do we advise them to lose weight? Do we ask them to avoid gaining any more weight? Should we be going for these American guidelines of an increase of between 5 and 9 kilograms? So I started to look into where some of these guidelines have come from and where some of these fears about losing weight in pregnancy have come from. And actually, a lot of the evidence that suggests we should tell women not to lose weight in pregnancy comes from really extreme circumstances. So women who may follow a very restrictive diet, for example, a very low carbohydrate diet, there's going to be all kinds of metabolic consequences of following such a diet in pregnancy. There's a risk of metabolic ketoacidosis, there's a risk of renal dysfunction. And one of the most famous studies that people often refer to in terms of weight loss in pregnancy is the Dutch famine study, where pregnant women were severely restricted of food intake during the Second World War. And this study found that women had energy intakes between 600 and 1,500 calories. And this was associated with increased risk of prematurity, stillbirth and neural tube defects in the first half of pregnancy, or with low birth weight in the second half of pregnancy. But as I said, really extreme circumstances. We wouldn't be asking any of our pregnant women to have an energy intake of 600 calories in pregnancy. So are these fears about weight loss in pregnancy, founded, or are we kind of sending a lot of these women down the wrong path? And this is really kind of following on from what Margaret's found now, and I also, just like Margaret, believe that quality rather than quantity is the key. The examples that we've had of where there have been adverse pregnancy outcomes because of reduced dietary intake, that's not just an energy deficit, that's a deficit of all nutrients. In the Dutch famine study, those women had very low intakes of iron, calcium, protein. It wasn't just an energy deficit. And certainly as a dietitian, my approach was to offer these women sensible, healthy eating advice, very much what you were suggesting earlier. So focusing on the quality rather than the quantity, and absolutely that may involve eating more food, but it's better quality food. It's not filling up on all the rubbish, on all the empty calories, which is deficient in many micronutrients. And a lot of my approach really followed what I used to do with women who referred to me with diabetes. So my main role at the Women's Hospital was seeing women who were diagnosed with diabetes in their pregnancy. And if you think about the type of advice as a dietitian you would be giving to women who have diabetes, we talked about regular meals, so not skipping meals, eating at regular intervals, avoiding high sugary food and drinks, avoiding sweet desserts, snacks, cakes, chocolate, and suggesting alternatives of foods that they could eat instead. So things like fruit, yogurts, maybe the plainer type of cakes and biscuits, avoiding sweetened breakfast cereals, eating more fruit and vegetables. So that's the kind of healthy eating dietary advice we would give to women with diabetes. So I suggest that's also the type of dietary advice we should be giving to overweight women. And if they lose a bit of weight, I wouldn't worry too much about that. So, without even mentioning weight loss or reducing calories, some of these simple changes to diet that involves reducing sugar intake can, as a byproduct, result in a lower calorie intake. So this is just a few kind of suggested changes that we may make to the diet of pregnant women with diabetes. So, swapping their can of Coke for water, stopping having sugar in their tea, having plain biscuits instead of chocolate biscuits, having plain cereal instead of sweetened cereal. Little changes like that which involve not eating any less food, but eating less sugar in the food that they're consuming. And just those simple changes that I've suggested there could result in a saving of over 300 calories per day. which is not massive, but certainly for somebody who's very overweight, could make a significant difference. So this healthy eating approach, there's no over-restriction of energy. We're encouraging a regular intake, and we're also encouraging the micronutrient intake from other foods. And I just wanted to end with a little case study of an actual patient that I had at the Women's Hospital, who was a woman who presented at clinic with a booking in weight of 103 kilograms and a BMI of 42. She was newly diagnosed with gestational diabetes at 19 weeks into her pregnancy. This was her diet history. So you can see there was a bit of meal skipping going on. There were some very high fat, high sugar type foods in there, not much fruit and vegetables. So lots of scope for improving the overall quality of her diet. So what we did was we encouraged her to reduce her sweets, to replace her sugary cereal with a low sugar cereal, to limit some of her high sugar drinks, to reduce some of her high sugar cakes and biscuits and have plain ones instead, and to eat more fruit and vegetables. And we didn't actually mention losing weight at this point. We just talked about improving overall quality of diet. And this is what happened. She took on board the advice, she made lots of changes to her diet, she was eating regular meals, she was no longer skipping her meals, she said she didn't feel hungry, and she actually managed her diabetes really, really well with low sugar diet alone, so we didn't need to introduce any kind of medication or insulin with the diabetes. And the last time we saw her in this pregnancy was 38 weeks prior to induction, and she'd actually lost 3.6 kilograms since her diagnosis. So again, not massive, but a significant reduction in weight considering that she was pregnant. As I met this lady again 2 years later when she appeared at clinic, this time diagnosed with gestational diabetes at 30 weeks, so much later in her pregnancy she was diagnosed with gestational diabetes, and this time her weight at booking in was 91 kilograms and her BMI was 37. So between the first pregnancy and the second pregnancy, she'd actually lost 12 kilograms in weight. And not only had she lost more than 10% of her body weight, which is seen as the gold standard in terms of maintaining weight loss, she'd actually maintained this for 2 years in between her pregnancies. And when I asked her how she'd managed to do it, she said, well, everything you told me last time was so easy, I just carried on doing that. And she'd kept to that diet for 2 years, and that was the result. So just to summarise, obesity in pregnancy is increasing in both prevalence and severity, and women who have severe obesity in pregnancy, it's classed as a high-risk pregnancy. Healthy eating may encourage the quality of their diet, whilst reducing excessive calories, and that really we need to do something about the current guidelines for managing obesity in pregnancy, as they are very vague and very unhelpful, and we need much more evidence in this area. Thank you.